T1 lesions of the esophagus. High-grade dysplasia in Barrett esophagus is most powerful predictor of subsequent invasive carcinoma and is associated with per year cancer incidence of 6%. Okay, so high-grade dysplasia per year incidence of cancer is 6%, and thereby warranting therapeutic intervention. The rationale for esophagectomy is that resection completely eradicates the mucosa at risk and which prevents progression to invasive carcinoma, and this is supported by older surgical series reporting previously unidentified invasive cancer which was present in up to 40% of the resected specimen. The argument against esophagectomy is that most patients with high-grade dysplasia do not develop invasive carcinoma in their lifetimes, and in the era of endoscopic resection, that early cancers can be effectively addressed without any esophagectomy. And those supporting an endoscopic method ranging from surveillance to mucosal ablative and resection techniques argue that this allows for the identification of the patients with an early invasive lesion that is readily and amenable to cure or elimination of the mucosa at risk, thus preventing progression. Indeed, patients with superficial invasive tumors confined to the mucosa and those with T1A disease in particular have little or no risk of lymph node mets and are considered candidate for endoscopic therapies. Select patients with T1B lesions with limited submucosal invasion as SM1 may also be considered for endoscopic submucosal dissection, although deeper invasive identified on final pathology will review in most instances require additional treatment. Now, ablative methods, mechanism of action of all mucosal ablative techniques including photodynamic therapy, laser ablation, multipolar electrocoagulation, argon plasma coagulation, cryotherapy, radiofrequency ablation is a destruction of the mucosal layer. The premise for managing high-grade dysplasia with endoscopic ablative therapy is that mucosal injury in an acid-controlled environment via PPI eliminates the pre-malignant mucosa and resurfaces the esophageal lining with regenerated squamous epithelium. In addition, ablative therapy has been demonstrated in a multi-center randomized clinical trial to reduce the risk of progression to high-grade dysplasia and or adenocarcinoma. Ablative therapy has no role in setting of non-dysplastic Barrett esophagus. Photodynamic therapy involves the administration of an inactive photosensitizing agent that, when exposed to a light of the proper wavelength, results in oxygen radical production and tissue destruction. The results of this phase 3 multicenter study randomized 208 patients on 2-to-1 basis to either photodynamic therapy plus omeprazole or omeprazole alone demonstrated improved eradication of high-grade dysplasia in the photodynamic therapy arm. At 24 months follow-up, when a marked reduction in the occurrence of adenocarcinoma was noted with photodynamic therapy treated group. However, results emphasize the risk of development of invasive cancer in a relatively short-term interval of 24 months. And this result highlight the limitations of photodynamic therapy due to the complexity of treatment and inconvenience of exposure to photosensitizing agent. Photodynamic therapy has fallen out of favor. Limited experience with thermal ablation for high-grade dysplasia has been reported. Small series of either laser ablation or argon plasma coagulation of high-grade dysplasia suggests that high-grade dysplasia can be eradicated. However, the follow-up period in these studies was short and invasive carcinoma was subsequently been documented. Radiofrequency ablation is now considered the preferred ablative technique. Radiofrequency ablation. For non-nodular Barrett esophagus, a randomized trial of 127 patients of Barrett esophagus, either low or high-grade dysplasia, assigned patients to either a sham endoscopic procedure or treatment with radiofrequency ablation. Patients assigned to receive radiofrequency ablation were treated with a circumferential ablation device employing an inflatable cylinder balloon, bringing electrodes into contact with the esophageal lining, with 4 applications performed per session, and up to 4 sessions performed over 9 months, and at 12 months, a complete eradication of metaplasia occurred in 77.4% of the radiofrequency ablation patients, compared to 2.3% in the control group. Although the development of cancer in either group was uncommon, progression to cancer in an ablation group was significantly less than that in the control group. Now, endoscopic resection, EMR. Endoscopic mucosal resection is now considered an essential diagnostic staging therapeutic option available for patients with either high-grade dysplasia or superficial esophageal cancer T1A. Endoscopic mucosal resection technique either involves a submucosal injection of fluid to lift and separate the lesion from the underlying muscular layer, or the use of suction to trap the lesion into cylinder, which allows for a full resection and tissue retrieval with a snare or endoscopic knife for appropriate histological examination. Al et al. Prospectively examined the utility of endoscopic resection in 100 consecutive patients with low-risk adenocarcinoma, no ulcer, mucosal lesion, no vascular lymphatic invasion, less than 2 cm, not poorly differentiated. Complete local remission was achieved in 99 of 100 patients. At a median follow-up of 33 months, 11% of the patients developed recurrent or metachronous carcinoma, all successfully treated with repeat endoscopic resection. And the calculated 5-year survival rate was 98%, and no patient died of esophageal cancer. In a previously study from the same group, complete remission rate in patients with less favorable lesion was 59%, which emphasizes the need to adhere to strict criteria to optimize disease eradication. The report examining the value of EUS and EUS guided FNA in patients with high-grade dysplasia or intramucosal cancer considered candidates for endoscopic therapy and demonstrated that 20% of the patients had unsuspected lymph node mets and were therefore deemed unsuitable for endoscopic interventions. And this results and similar findings in smaller series examining EMR confirm the use of this technique is feasible for the treatment of high-grade dysplasia and carcinoma limited to a mucosa T1A and provides an alternate to esophagectomy. Furthermore, patients carefully screened and confirmed to have mucosa limited lesions should first be offered EMR prior to considering an esophagectomy. Endoscopic submucosal dissection developed in Japan. They have been examined a relative small group of patients with limited invasive esophageal carcinoma, including T1B lesions with superficial submucosal invasion SM1. And studies have demonstrated that this endoscopic submucosal dissection is a safe and effective treatment with favorable 5-year survival rate in properly selected patients. However, in one of the large retrospective studies of endoscopic resection with long-term follow-up or multivariate analysis, PT1B SM2 was associated with decreased overall survival and relapse-free survival, while definitive chemoradiation or esophagectomy was associated with improved overall and relapse-free survival. So, multi-center studies will help define appropriateness of endoscopic submucosal dissection in the future. Although patients with poor pathological features such as lymphovascular invasion and more than limited submucosal invasion should be educated on the relative value of more traditional therapeutic approach. Thank you.